Hypersensitivity Pneumonitis, HP. By Zebalukzadeh, MD. Occupational Medicine Department. Yazd University of Medical Sciences. Definition: immune, hypersensitive, response. Extrinsic allergic alveolitis, granulomatous, interstitial, bronchiolar and alveolar filling lung diseases caused by repeated exposure and subsequent sensitization to a variety of organic and chemical antigens. Etiology: microbial agents, animal proteins. Low molecular weight chemicals. Microbial agents: bacteria, fungi, amoeba, bagasosis. Farmer's lung. Bagasosis. Mushroom worker's lung. Fungi. Wood pulp worker's lung. Cheese washer lung. Amoeba. Humidifier lung. Bacteria cause occupation agents source major antigen farmer's lung. Agriculture worker. Moldy hay. Thermoactinomycete. Mushroom workers. Mushroom worker. Compost. Bagasosis. Bagus worker. Moldy. Sugarcane. Animal proteins, avian proteins, bird breeder's lung. Urine, serum, pelts, animal handler's lung. Wheat weevil lung. Chemicals. Isocyanate HP. TDI, MDI, HDI. TMA, HP. Trimolytic anhydride. Pathogenesis: immunology. Repeated inhalation of antigens. Sensitization: immunology. Response type 3, 4, influx of neutrophils, shift T lymphocytes, ~70% predominantly of CD8. Antibodies in HPRIG class. Response delay by 3 to 8 hours. Pathogenesis, CONT, host factors, polymorphism in TNF-alpha gene. Non-smokers greater than smokers. Polymorphism in TNF-alpha gene. No association with HLA. Pathogenesis, CONT, exposure factors, Ag concentration. Duration of EXP. Frequency and intermittency of EXP. Particle size. Use of respiratory protection. Farmer's lung disease, winter. Bird breeder's lung, summer. Indirect exposure. Clinical features. Acute HP, fever, chill, myalgia, cough and dyspnea plus bacillar rails in pH/E, 4 to 12 hours after heavy exp. Recurrent febrile episodes, most frequent presentation. Subacute and chronic HP, insidious onset of respiratory symptoms, malaise, fatigue, weight loss plus bacillar rails, wheezing, cyanosis, right-sided HF in pH/E. DDX inhalation fevers, others granulomatous disorder, sarcoidosis. Immunologic disease, asthma. Infection. Fibrotic lung disease, IPF. Comparison HP in inhalation fever. Feature. HP. Inhalation fever. Example. Farmer's lung disease. Metal fume fever. Etiology. Thermoactinomyces. Zinc fume fever. Pathophysiology. Hypersensitive reaction. Cytokine mediated. Exposure dose. Low dose. High dose. Sensitization required. Yes. No. Comparison HP in inhalation fever, CONT. Feature. HP. Inhalation fever. Fever. Yes. Flu-like syndrome. Cough. Expected. Not necessary. Dyspnea. Not typically. Chest exam. Rails. Normal. Comparison HP in inhalation fever, CONT. Feature. HP. Inhalation fever. CXR. Alveolar infiltration. No. PFT. Decreased DLCO and volumes. Minimal change. BAL. Lymphocytosis. In increased neutrophils. Chronic sequel. Yes. None. Natural HX. Recurrent or progressive. Complete recovery within 3 days. Lab. Studies precipitin AB. Helpful but not specific, not sensitive, not hallmark. Leukocytosis, mild elevation of ESR, SHI, IG, IgA, IM, ACE, ANA, PFT normal, early DIS, restrictive obstructive mixed. Decreased DLCO, most sensitive physiologic test in early HP, CXR. Acute, diffuse ground glass, fine nodular or reticulonodular pattern, lower lung. Subacute, reticulonodular pattern. Chronic, fibrosis, reticular opacity, honeycombing. Mediastinal lymphadenopathy, up to 50%, HRCT ground glass central lobular nodules A-space consolidation. Mosaic pattern. Fibrosis. Emphysema. Normal CXR. Histopathology classic triad, cellular bronchiolitis. Lymphoplasmacytic interstitial infiltration. Non-necrotizing granuloma, diagnosis. Temporal relationship between symptoms and certain activities is often the first clue to the diagnosis of HP. Diagnosis: environmental history, pets and other domestic animals. Hobbies such as gardening and lawn care. Recreational activities, for example, use of hot tubs and indoor swimming pools. Use of humidifiers, cool mist vaporizers, and humidified air conditioners. Moisture indicators such as leaking, flooding, or previous water damage to carpets and furnishings. Diagnostic criteria required: appropriate exposure, supportive. Dyspnea on exertion. Inspiratory crackles. Lymphocytic alveolitis. Supportive. Recurrent febrile episodes. Infiltrative on CXR. Decreased DLCO. Precipitating antibodies. Granulomatous on lung biopsy. Improvement with contact avoidance. Treatment: best treatment, removal from exp. Preferred approach: elimination of AG. Oral corticosteroid, in severe or progressive disease. O2, inhaled steroid and B agonist in airflow limitation.